Good morning, everyone. Welcome back to IshCon 2024. Today is the third and final day of the event, and we have already witnessed some great discussions. So, without any further ado, let's start today's free paper session. And I would like to invite and welcome upon our respected chairpersons, Dr. Sanjay Kumar Giri and Dr. Ajish S. Welcome, sir, and I would like you to proceed further.
Yeah, so let's start on time today. I'm sure a lot of us are groggy from yesterday. I am certainly. So anyway, so we have the first paper is on vascular malformations by Dr. Subhashini.
Good morning, everyone. Respected chairpersons and dear friends. Vascular malformation refers to the abnormal dilatation of vessels without endothelial cell proliferation. Once the endothelial cell gets proliferated, it comes under the category of vascular tumors. This is the ISWA classification. Here in this, we are going to see only the arteriovenous malformations of the vascular malformations. So this is a patient number 1. She's a 50-year-old lady who had this for almost 30 years. 20 years back she underwent an amputation. Now she has come with recurrence of the lesion, and this is her MRI. Due to long-standing nature, we can see that the radial and ulnar artery was also tortuous and dilated, and we can see there is a big mass of tumor in the palm and involving the dorsum of the first web space also, and there were changes in the axillary artery also. So this is intraop. Whenever we approach a vascular tumor, it is better to start from the area where the lesion is less and get a proximal control first and then proceed with the reduction of the tumor. We don't call it as excision because we cannot remove entirely completely, and we always call it as reduction and tell the patient that there is chance of recurrence. And once we remove the tumor, we release the tourniquet, check for viability, and also for any obvious macroscopic pulsatile mass which is present. And in case there is a vascular compromise, our backup plan would be to revascularize the finger with a saphenous vein graft. This is the patient with the late follow-up. This is a movement. She came to us. She has some amount of recurrence in the first web space dorsum, but she came for carpal tunnel symptoms. This is a second patient. He is a 20-year-old male. He presented with this high flow arteriovenous malformation. Here we found that the common digital artery in the web space was also involved. In the third web space also was involved, but the branch to the ring finger was not much involved, and the common digital artery in the fourth web space also was involved, and the branch to the little finger was not much involved. As the ulnar side was more, we decided to attack the ulnar side first, and this we removed the ulnar side vessels. This is the post-op photos, and the patient came to us after 2 years with recurrence. This time also we found the radial side was obviously enlarged, and there were connections, and ulnar side also we had some of the malformation. This we have preserved both the digital nerve and removed the ulnar side vessel. Currently he is not having any recurrence. This is a patient who came to us after one sitting of reduction 6 months back elsewhere. The tumor has grown. The dotted line, within the dotted line is the tumor which is involved, the malformation which is there, and that tip area found to be uninvolved, but there was a malformation in the nail bed region also. So we excised. On removing the tourniquet, we found that the terminal phalangeal region tumor was more. The first one is the first picture after reduction. The second picture shows the nail bed involvement. We opened the nail bed and curated the malformation. And the last picture is after the final reduction. After removing the tourniquet, we reassessed and reduced it. He developed by 2 weeks necrosis of the skin, but he was not involving for reconstructive procedure we offered, managed conservatively. He had a deformity, PIP joint flexion contracture was there, and there was an unstable scar in the ulnar border. This is a one 1 year 2 months old child who came with a low flow arteriovenous malformation in the dorsum of the first web space. This child, we took the help of the intervention radiologist. Intralesional lipoidal with alcohol was injected. This is 2 years later follow-up of the child. The child has minimum palpable tumor but no symptoms and no increase in size. She is on annual follow-up. So we have to assess and counsel the patient what we can realistically do and what we have to expect. Proximal control of the lesion is first, and judicial use of radiological intervention is very helpful. And before finishing the surgery, better to release the tourniquet and reassess what is the status of the malformation and then proceed. Thank you.
Thank you. Any questions for Dr. Subhashini? The difficult problem that comes up, arteriovenous malformations.
I just have a question.
Yes, sir.
In the first two cases, that whatever you have seen, that AV malformations, don't you have used the intervention radiology people to? Because
we do have, sir. Those both are high flow arteriovenous malformation. We can't proceed. We can do embolization and take up for surgery. Those two patients were not willing for that. We have some set of patients who can't afford for both.
Because it is too difficult to remove all the things.
Radiological alone will not help.
Yeah.
We can embolize and take the patient for surgery same day or next day. The option has been provided to them, but they were not.
Thank you.
Thank you.
Second is the toe glomus tumor of a 34-year experience by Dr. Karthik.
Good morning, chairs and the audience. I'll be presenting our experience of treating toe glomus tumors at our institution of the past 14 years. So I come from the Christian Medical College, Vellore. There are no disclosures. So they were first described by Wood in 1812 as painful subcutaneous nodules. Later, Barr and Manson in 1924 described them as benign vascular hematoma. They often occur in the skin and subcutaneous tissue, often in the subungual region of the upper limbs. Rarely in the toes. Like they present with classic triad of pinpoint tenderness, cold sensitivity, and severe paroxysmal pain. So clinically we can see Low's test, which is pinpoint tenderness, Hilder test, which is demonstrated by disappearance of pain on exsanguination of the limb and application of a proximal tourniquet. The pain might also recur on release of the tourniquet. Joseph-Posner test is demonstrated by the occurrence of pain on application of ethyl chloride over the lesion, or the site of the lesion. This is a picture of glomus tumors. Here we can see nests of glomus tumors in a myxoid stroma, and here's a higher resolution showing glomus cells. So we reviewed the medical records of all the patients treated at our institution for the last 14 years, and we looked at the toe glomus tumors, and then curated their demographic data from our records. And follow-up data was obtained from the outpatient records. And if they have not followed up within the last 6 months, we have called them up to ask for any recurrence of symptoms. So this is one of the toe glomus tumors that I had accessed 1.5 years back. So we use this approach for most of our subungual tumors, transungual approach, elevate the nail plate by a careful, non-atraumatic dissection. And then following the removal of the nail plate, we give a eponychial incision based on the need for better exposure. Then we identify the toe glomus tumors by the bluish hue. This is a linear incision along the location of the site of the glomus tumor. After which, then we do sharp dissection. Sorry. Not able to slide further. Yeah. So then, following which the pedicule is identified, then it is cauterized, avoiding injury to the nail bed, and then excised. Then the nail bed is repaired by absorbable sutures, and we replace the nail plate of definition of the nail plate. So 9 patients were treated at the institution over the last 14 years, 1 male patient and 8 female patients. Mean age was 33 years and mean duration was 6.5 years, with 1 patient having symptoms for almost 20 years, like with multiple clinician visits. The tumors were primary in 7 patients. 2 patients had attempted excisions elsewhere. Low's test was positive in all our patients. Cold sensitivity was positive in 56% of our patients. That's 5 out of 9. Grade toe was involved in 5 of the patients, 3 in second toe, and the third toe was involved in 1 patient. Plain radiographs were used for 7 patients, and 3 of them showed some scalloping. Ultrasound was used for 3 patients, and MRI was 3 patients respectively, and both of them showed presence of toe glomus tumors whenever they were used. 1 patient who had underwent an MRI and ultrasound, both, usually we don't do it, he was initially evaluated by another unit and then referred to us. And both of them showed the tumors. So all were operated, the tumors were operated by 4 different surgeons who had operated, between them they had operated at least 125 tumors among themselves. So all the tumors were located in the subungual region, and the mean size of the tumors was 4.9 millimeters. The largest one was around 7 millimeters. We had a mean follow-up of around 57 months, that's around 5.5 years. 2 patients had recurrence, 1 recurrence at 3.5 years, another was operated at around 7 years and 8 months later. So after the re-excision, nobody had any further recurrences. The mean SANE score of the toe compared to the normal side was 95.5%. So this is a 9-year follow-up of a patient who underwent excision 9 years back. So the right toe is the operated toe, the left is the normal toe. So this is a 1 year follow-up of 2 patients showing good regrowth of the nail with probably minimal deformity, almost the same. So we conclude that excision of the toe glomus tumors is curative with satisfactory results in most cases. Recurrence may occur and they can be satisfactorily treated with re-excision. Thank you. This is our team. I thank God and our mentors.
Any questions? What is SANE score? SANE?
It's a single assessment numerical score, which helps to simplify the evaluation both for the examiner and for the patient. So it's been validated. We just ask the patient, how do you rate the toe or the limb compared to the opposite side? And the patient gives a single score, and they've found that using extensive scores and SANE score kind of correlates to almost 90% correlation is there.
Thank you, Dr. Kadir.
Thank you.
So we'll have our next talk. That's from Dr. Naveena. And he's talking on the comparative study of efficacy between platelet-rich plasma and other mode of conservative management in lateral epicondylitis.
Good morning, everyone. My topic is about comparative study of platelet-rich plasma versus other mode of conservative management in lateral epicondylitis. So as we know, the lateral epicondylitis is a pain and tenderness, present with a pain and tenderness over the lateral epicondyle due to the overuse of forearm extensor muscles, especially ECRB, extensor carpi radialis brevis. So incidence is 1 to 3%, and 35 to 55 years is a common age. So pathophysiology being the microscopic tear of the ECRB due to the abnormal vascularity and disorganized collagen fibers. So diagnosis is mainly a clinical. So as we all know, the Cosen test for the tenderness over the lateral epicondyle on resisted extension and gripping. So this is the Cosen test. The investigations are not needed. It's mainly a clinical diagnosis, but to rule out the other pathologies, we are doing the X-rays and dynamic ultrasound as a differential diagnosis to rule out the radial tunnel syndrome. So the treatment options consist of rest, modification of activity, and physiotherapy, which involve the stretching and strengthening exercises for the forearm, extensor forearm muscles, and as well known NSAIDs and counterforce bracing. Though corticosteroid has been tried with variable benefits, mainly the short-term benefits, but the long-term benefits of corticosteroid is questionable, and it do not alter the course of disease. So there is a more chance of relapse, and also repetitive use may lead to tendon weakening and rupture. So in recent years, the platelet-rich plasma has come with great benefits, biological healing of the tendon, So mainly it contains it's autologous blood product which contains a rich concentration of the platelet, so which is rich in growth factors like platelet derived growth factor, vascular endothelial growth factor, TGF beta and FGF. So it has some limitations like variability of preparation techniques and lack of standard protocols for administration, and commercially it's a high cost. So we did a prospective observation study in our center from April 2018 to August 2019. The sample size being the 44 patients. Sample size is calculated on standard protocol, and inclusion criteria being the 18 to 60 years of age, and signs and symptoms of lateral epicondylitis, and willing to follow up for 6 months, and the consent being included. The exclusion criteria being the children less than 18 years and elderly patients more than 60 years, and diagnosis other than lateral epicondylitis. For that we are doing the X-ray and ultrasound to rule out other pathologies, and previous any surgery or elbow pathology, and pregnant ladies. Coming to the randomization, it is done by a simple randomization using a computer generated randomization table. So group A consisting of 22 patients with PRP, and group B 22 patients with other mode of conservative management. So PRP preparation is done. There are so many methods of preparation, but we went ahead with this article. The 15 ml of patient venous blood is collected in 3 tubes, and then centrifugation done in 1500 RPM for 50 minutes. So on the supernatant is discarded. Then again all the 3 tubes are centrifuged for 2500 RPM for 10 minutes to prepare the 1 ml of PRP. The sterile preparation is done, and PRP is injected to the maximum portion of tenderness in and around the tendons. So conservative management, mainly the physiotherapy and NSAIDs and counter brace. So we have the continuous physiotherapist protocol. So, and the evaluation is done by the patient rated tennis elbow evaluation. It's a 15 term questionnaire. So this is the evaluation, and PRT score done at the baseline 4 weeks, 8 weeks, 3 months and 6 months. So results, the age, this is the age distribution and sex distribution. So the total PRT comparison, we can see there is a up to 8 weeks, there is no much difference, but after 8 weeks, 3 months and 6 months, there is a significant improvement in the PRT score in PRP compared to the other modes of conservative management. So this is the this is also showing the same thing. So conservative management at 8 weeks it is good, but for PRT, long term platelet rich plasma, the long term PRT is good. So to conclude my study, it's other mode of conservative management like analgesic, physiotherapy and counter base appear better in the short term, but the long term benefits, the PRP is superior. But we have no complications in either group, and but still the more research required to know the long term efficacy of PRPs. Thank you.
Thank you. Any questions for Dr. Navina? Tennis elbow. Thank you, Dr. Navina.
Thank you, sir.
We'll move to the next speaker. Anmele. Dr. He's not. Dr. Sara. Not here. बोल दो जो भी. Dr. Manju. Topic is peripheral nerve tumors of the hand, tips for pre and intraoperative decision making and management.
A very good morning to all. I am Dr. Manju, Senior Resident from the Department of Plastic Surgery, AIIMS, New Delhi, presenting today peripheral nerve tumors of hand, tips for pre and intraoperative decision making and management. So peripheral nerve tumors of hand are not uncommon entities, and this we encounter in our clinical practice, and the incidence is reported to be of less than 5%, and commonly they are of benign in nature, and schwannomas are the most common benign peripheral nerve tumors, and others include neurofibromas, perineurioma, and neural fibrolipoma. Even though very rare, malignant peripheral nerve sheath tumors are also there. And our aim is to evaluate the intraoperative challenges and outcome of different kind of peripheral nerve tumors. And we are presenting, I'm presenting today 4 cases of peripheral nerve tumor that we have operated in last 1 year. So first case is that of a 28-year-old male patient who presented to us with a painless swelling, which was therefore, which was gradually increasing in size for the last 11 years. And on clinical examination, the swelling was non-tender and was extending from the ring finger approximately till the wrist joint. And it was firm and mobile from side to side, but it was immobile in the axial direction. And there was no sensory deficit. And this is, this is the MRI of the patient showing T1, first image is that of T1 weighted MRI, which showing intermediate signal intensity in the ring finger region. And the figure B is showing the proton density weighted image with fat suppression showing the hyperintensity. And the last one is the sagittal view showing the lesion abutting the bone. So intraoperatively, the zigzag incision was made over the swelling, and the lesion was dissected under microscopic magnification so as to avoid injury to the nerve fascicles and surrounding structures. And the lesion was multilobulated and well encapsulated, and it was dissected out, and the nerve was preserved. And on histopathological examination, it was suggestive of schwannoma with a well-defined capsule. There were Verrocchio bodies, Antony A, hypercellular areas, Antony B, and it was strongly positive for S100. And case 2 is, has a similar presentation with painless swelling, and it was there for 3 years, and it was in the thenar region. The only complaint of patient was decreased range of movement while making the fist. And on examination, it was non-tender and was lying over the thenar region, and there was no sensory deficit. And intraoperatively, a well-circumscribed lesion was there, but the median nerve was continuing distally through the lesion, so it was inevitable to excise the median nerve along with the lesion. And followed by that, there was a 7.5 centimeter gap. It was reconstructed with cable grafts using from sural nerve. 2 grafts were used. One was coapted with the ulnar and another with the radial digital nerve distally. And in follow-up, patient has achieved the sensory recovery by 8 months, and again on histopathological examination, it was a schwannoma. And case 3 also presented with a swelling over the right thumb and thenar region and associated with on and off pain. The intraoperatively we have there was a multilobulated longitudinal swelling from the thumb, and it was excised, the nerve was preserved, and the histopathological report came out to be schwannoma. Post-operatively, there was no sensory deficit. And case 4 is that of a 13-year-old female child who presented to us with a swelling in the right palm, which was there for past 9 years. And clinically, there was no functional deficit. So intraoperatively, again, zigzag incision was given over the swelling. But in contrast to the other cases, the lesion was very diffuse, and on exploring more proximally, the nerves were thickened, median nerve was thickened, and since there was no sensory deficit preoperatively, the decision was taken to debulk the swelling, and this postoperatively scar is settled well, and there was no deficit in the median nerve region. And to conclude, the peripheral nerve tumors are not uncommon, and for a better outcome, we have to do a thorough clinical examination, imaging, and preoperative discussion with the radiologist will help in diagnosing the type and extent of swelling. And it is important to do preoperative counseling regarding the extent of excision or debulking, or if there is a chance for need for nerve excision followed by reconstruction. And intraoperatively, if the dissection is done under microscope and use of nerve monitor will help in the preservation of nerve function. And it is important to follow up the patient post-operatively so as not to miss any malignant changes in the lesion. Thank you.
Any questions? In the first case, you have shown that tumor that arise from the distal nerve.
Sir, it was extending from the distal carpal tunnel and it was
No,
extending.
first case in the finger only.
Sir, it was involving the common, means it was around abutting the distal common digital nerve and proximally it was coming till near the median nerve. Thank you.
Okay. So the next talk is from Dr. Raghav Shrotriya. He'll be talking on the outcome analysis of free functioning muscle transfers and brachial plexus injuries.
Good morning, everyone. So traumatic brachial plexus injuries are quite devastating for the patients, and plexus exploration and nerve grafting are the primary standard treatments for the patients presenting in the earlier phase, that is 6 to 8 months of injury. For the patients presenting later, free functional muscle transfer using Gracilis has been found to be good in various permutations and combinations. So in this paper, I would be talking about our experience in FFMT for the BPI patients. So this is a retrospective study of all the patients suffering from BPI and treated with FFMT in the last 5 years. We evaluated the active range of motion, MRC grading and complications, and the data was collected from the patient records and photos and videos. So shoulder stabilization is a prerequisite for this procedure. For the global palsy patients, the neurotization targeting either the suprascapular nerve with or without the axillary nerve or the trapezius transfer should have been done prior. Patients counseling is very important about the complications, expected scars, extent and expected outcomes of the surgeries, need for prolonged therapy, multiple surgeries, all these things are very required to be told. Detailed planning is done, and videographic record of the motor function is also very useful in evaluating the results later. The pec major and latissimus dorsi muscle power should be evaluated. At sometimes they return back after some time, and they may be potential options for pedicle functional muscle transfer. Two-team approach is helpful since it is quite an extensive surgery with long timing. So we start with the one team starts with the gracilis harvest. Around 35 to 40 centimeters of gracilis muscle may be harvested. The intercostal nerves are harvested and kept ready from the chest. The thoracodorsal artery and vein are also dissected, and the flow is checked and kept ready. 220 polyamide sutures are passed through the second rib periosteum, and they are kept ready to receive the gracilis muscle. In the forearm, the FDP tendons are identified and looped. The gracilis is then separated and attached to the second rib with the ethylon sutures. The anastomosis is done keeping the ischemia time of the muscle less than 60 minutes. Since it is going to be a functional muscle, you need to minimize the ischemia time. Nerve coaptation is then completed. The muscle is then tunneled across the elbow into the forearm under pronator teres to prevent bowstringing, so it acts as a pulley. All the proximal suture lines may then be closed, and the tension adjustment and pulvertaft weave for gracilis for all FDP tendons is done. So try to minimize the things that you want to do after the tension adjustment. So alternatively, depending on the patient's status, there may be a variation in the proximal attachment, the distal insertion, the vessels and nerves that we use, but the basic steps will grossly remain the same. So we had total of 14 patients. Out of these, 9 were operated for elbow flexion with finger flexion. 3 each were operated for elbow flexion separately and finger flexion separately, and there was one double functional muscle transfer. Around 65% patients got more than M3 power, and 2 patients had vascular issues in the post-op period and did not gain usable power. One patient had seroma in the chest, which was managed conservatively. So the first patient that you can see is 2.5 years post-op done for finger flexion. The next one is 28 months post-op only for finger flexion, and the third one is for elbow flexion. So these are patients for elbow and finger flexion again. This patient is 2.5 years post-op for elbow and finger flexion. So Terzis et al. Said that at 6 months from injury, FFMT will be preferable for elbow flexion instead of intercostal nerve neurotization. And according to some authors, the beginning of reinnervation of the gracilis muscle around 3 months and can continue up to 2 years. So in our series also we have got the signs between 4 to 6 months. A point is that when single FFMT is being used for elbow flexion and finger flexion, the elbow flexion comes to start early, and once it is around 2/5 power, the elbow restricting splint is given so as to allow the gracilis to flex the fingers primarily, and gradually the splint is weaned off. FFMT is a reliable surgical options for elbow flexion and finger flexion in the patients who have late presentations, and meticulous planning and patient selection are important. In spite of the best results, this limb continues to be a supportive limb. That is a main issue. Thank you.
Thank you, Dr. Raghav. Any questions for Dr. Raghav? Well, you said you had done a double FFMT as well in one of the patients?
Right.
And that was for?
That was for, the first one was for elbow flexion and finger extension, and the second one was for only finger flexion. So the one issue was that that is the main way of doing it, but some of the patients do not consent in the primary setting for 2 FFMTs. So then we started doing finger with elbow.
At the same time.
And this gives a lesser result as compared to the FFMT is done separately. But then it is useful. There is some bowstringing at the elbow, but they are happy with it.
So you told first after coming elbow flexion, you have to give a splint, then try.
Right, that increases the function of the FFMT on the fingers if you restrict the elbow.
That is at how many days you have?
Generally, we do it once the patient gets around 2/5 power. So maybe around 3 or 4 months it goes like that. It's different in various patients. Along with the therapist, we decide that now is the time to give, so that it starts moving the fingers more.
Experience of using SAN, you are not using SAN, you are always using ICN.
No. So it depends on the where the insertion is. If we are giving only elbow flexion, then we will attach it to the lateral clavicle and then use the spinal accessory nerve. If we are doing the finger flexion only or along with elbow flexion, then I'll put it to the second rib and use the intercostals along with thoracodorsal artery. So that is what I told in various permutation and combination according to the requirement of the patient. We can plan that.
Thank you.
Thank you.
Dr. Tubo.
Good morning, everyone. I'll be presenting giant cell tumor of tendon sheath, a case series. The study was carried out in Kempe Gowda Institute of Medical Sciences from 2022. Introduction: giant cell tumor of the tendon sheath. They are benign nodular tumors that develop from the tendon sheath of both the feet and the hands. It's the second most common hand tumor. It usually presents in the third or the fourth decade of life and more common in females. GCTTS is also known as localized nodular tenosynovitis. It's distinguished by its multinucleated giant cells. It's commonly associated with a tissue swelling, and bone erosions have been reported in advanced stages. This entity was previously thought to be a reactive process, but now is classified as a neoplastic pathology. Local excision and preservation of the underlying tendons, digital arteries, and nerves is the mainstay of the treatment. And the tumor is usually surrounded by a pseudocapsule which aids in its excision. There is a high incidence of satellite lesions which require a thorough examination. Curettage to remove the cortical shell is recommended if the underlying bone shows erosion. And the local recurrence is nearly 14%, which is very high. Case reports. Case 1, a 43-year-old female patient presented to the orthopedic department with a history of swelling over the volar aspect of the distal phalanx of the left thumb since 7 months. On examination, the swelling was painless and approximately 502 centimeters, and it was hard in consistency. It was mobile in the horizontal plane, and it was not adherent to the underlying structures. The patient had no restriction of movements. Further evaluation with an ultrasonography of the swelling showed a solid hypoechoic lesion around the tendon, the volar aspect of the left thumb. And there was no evidence of increased uptake of vascularity or calcification. X-ray of the hand showed erosions of the distal phalanx of the left thumb. FNAC was carried out and it showed multinucleated giant cells. And an MRI was done which showed T1, T2 hypointense masses which are arising in close proximity to the flexor pollicis longus tendon. The procedure after pre-op evaluation, excision and biopsy was done under wrist block and a digital tourniquet. A curvilinear incision was made with the proximal phalanx of the left thumb. Blunt dissection was done under microscope and pseudocapsule was found to cover the tumor. And the underlying tendon was intact and no loss of integrity. The wound was closed and the mass isolated was globular and gray in color, measuring approximately 12 millimeters in diameter, and a histopathology examination of the same was done, which showed osteoclastic giant cells, and stroma had hemosiderin-laden macrophages and areas of hemorrhage and lymphoplasmacytic infiltration. This was the second case. The third case was the swelling was present on the lateral aspect of the middle phalanx of the right hand, and a lateral incision was made. A tumor measuring approximately 4 centimeters into 2 centimeters was excised, and a JES external fixator was applied after the same. And histopathology showed osteoclastic giant cells. Case 5, the patient presented in a similar manner, and there was evidence of 2 distinct swellings, and the continuity could not be appreciated on MRI. Intraoperatively, you can see 2 distinct swellings which were excised, and histopathology was done which showed multinucleated giant cells. Discussion. The etiopathogenesis is trauma, disturbed lipid metabolism, osteoclastic proliferation, metabolic disturbances, and vascular disturbances. Surgical excision is the accepted treatment, but there's a high rate of recurrence and the recurrence could be due to underlying conditions like erosions that shows the progression of the disease, and degenerative joint diseases, extension into the interphalangeal joints, and incomplete excision. Radiotherapy of 20 GY is divided. Daily doses of 2 GY was initiated for cases with erosions which was seen. To conclude, it is a slow-growing tumor of the tendon sheath, and in some cases there is erosion, and post-operative irradiation. It's debatable. Post-operative radiotherapy is debatable if it is useful or not, but it is initiated in cases with erosions and cases extending into the joint, which causes difficulty in complete excision. Thank you. And you should evaluate for presence of satellite nodules. Thank you.
Thank you, Dr. Tuba. Any questions?
Why JES was applied in that case?
The tumor was massive to give support, sir, and a better healing.
Okay. Did you cross the metacarpophalangeal joint?
Yeah, I did.
The fixator?
Yes, the fixator did.
Yeah, well, it's immobilized in extension. That is what is more surprising, is why it was immobilized in extension. Did it involve the bone? Was there a bony lesion or something?
There was no bony lesion.
There was no bony
lesion.
Then what is the role of fixator?
Any collapse, because the tumor being a larger size, indicates that there's more pressure over the bone, and recurrence, just keeping in mind the recurrence.
And majority of your histopath shows diffuse mitosis. Do you consider for a radiation therapy in all cases?
No, sir. Only if it has crossed the joint or involved the joint, or if there is bony erosions. Only 3 out of the 6 cases underwent radiation.
And how many recurrences in your series?
One has come back. The others haven't got back with.
Thank you.
Thank you.
Thank you, sir.
So I invite Dr. Dinesh Kadam. Yeah, and so we'll be talking on toe transfers and hand reconstruction.
Good morning, everybody, and respected chairpersons. I'll just show the few cases of toe transfers. This is a 12-year-old girl. She had amputation at the metacarpophalangeal joint, and then we just covered with the flap there. Then later we planned for a toe transfer on the right hand, and this is the second toe which was transferred. FPL was repaired, harvesting from the distal forearm, and this was the anastomosis. And then she also required a bit of skin grafting because of the raw area, and this was her function. She could do apposition, and she could lift the weight and write legibly and with nice handwriting. And this is 30 months post toe transfer. Donor side at 30 months. And this was a 29-year-old male, and we had the osmos interphalangeal joint level amputation. We also used the toe transfer for him, and of course the great toe was an option, but he was keen on the saving only the second toe. We did little bit of correction of the contour by VY transfer of the flap in the proximally, distally, so that the bulk is reduced. And this is slightly length is longer. Cracker blast injury, mangled extremity completely. Then we had only the fifth ray at metacarpal, and the thumb part of the proximal phalanx was intact. Metacarpal was intact, and this is second toe for the fifth ray. It was done almost 15 years back. And this is the anastomosis, and he had the arterial occlusion, and which was salvaged, explored and salvaged. He is able to use his daily living activities. This 19-year-old girl with including index finger and thumb was crush injury and loss. We did a groin flap initially, and then this was their defect. The second toe again, using the extra length of the metacarpal also to compensate for the length of the thumb, and a little bit of tendon release later. This is the post-op X-ray, and her activities she is able to hold, do fine activities. The cracker blast injury, including loss of thumb and metacarpal joint, second toe. So we do require a lot of skin cover also. We may need to do a bit of skin grafting if you have a good soft tissue cover. And this is this was done in 2008. and is able to oppose, is able to play right, and 25-year-old male with electrical burn with amputation on the right side, and this was on the left side with loss of thumb. Initial grafting with flap cover. It was like quite a bit of scarring there. You can see post-electrical burn. We had a problem with the venous selection. We had the venous thrombosis, which was again salvaged twice. We re-explored twice and then put the vein graft and this again local flap cover, and finally salvaged. And this is his activities with thumb. So I'll stop. Thank you. Basically, all these patients with loss of thumb includes metacarpal phalangeal joint and MCP joints, which may require extra length of the metacarpal when you take second toe. Other things are standard, which can, if you have a MCP joint intact, then it's easier to reconstruct. Thank you.
Thank you. Any questions?
Sir, in electrical burn especially, how you decide not to do in that cases, especially in they have an arterial compromise in majority of cases.
See, right side he had already had amputation below, so left, that was the only functioning, supposed to be functioning hand with loss of thumb again. So that was the, we took extra length of thumb because there was no metacarpal. So second toe was the best option. And you're talking about the arterial choice. Arteries should be available. I mean, in this case, it was not a problem.
Okay. And do you advise any extra feed of previous groin flap to avoid?
Yeah, it's better to have extra length of flap because it will always be useful. You saw some patients where we have to put graft, skin graft.
Thank you.
Yeah.
Great results, sir. What is the post-operative therapy protocol and all?
We keep immobilized for 6 weeks, keeping the K-wire. Sometimes I may keep to 8 weeks also. And then start mobilizing with the passive range of motions and then active. And 2-3 patients required tendinolysis and one patient actually wanted a change in the color of the skin because that was in the palm. So we took the glabra skin from the foot and then replaced that skin to this, and we basically switched the skins and it was a full thickness graft. Thank you.
Thank you, sir.
Thank you.
Dr. Krishna Prasad.
Today my presentation is on the role of adipose tissue transfer in peripheral nerve surgeries. So coming to introduction, the application of this autologous fat transfers we normally use in to improve functional forms in plastic surgery. So people, those who undergo peripheral nerve surgeries, only 40 to 50% of the people will have a good functional recovery. So the studies aim to provide an overview of scientific evidence on biology of adipose tissue, the role of adipose-derived stem cells, and indications of adipose tissue grafting in peripheral nerve surgeries. So the basic science nerve research suggests an increase in nerve regeneration and nerve revascularization and decrease in nerve fibrosis after addition of adipose-derived stem cells. So these derivatives of adipose-derived stem cells include macrofats, nanofats, or microvascular fragments. So after it undergoes manipulation, so we used nanofats in this study. So this fat grafting is an accessible method that keeps the cost low and it's minimally invasive and doesn't pose risk of any immune reaction, and also this fat grafting can be done in the same setting. So this picture shows the derivatives of the adipose-derived stem cells. So important is the Schwann cell, which is very much needed in the nerve regeneration. So aim is to study the subjective and objective outcomes of the fat grafting in peripheral nerve injuries and to study complications related to fat grafting. So all brachial plexus cases who underwent exploration, neurolysis, and nerve repair with or without graft, and nerve transfers like SN to SSN, Oberlin's, intercostal nerve transfers, and Somsack transfers were included in the study. And all nerve injuries other than brachial plexus and also were not included in the study, and contralateral C7, as it was not done in our institution, it was not included in the study. So sample size was 12, in that 8 upper trunk root lesions and 4 panbrachial plexus. Duration is 24 months. It's a prospective, and informed consent ethical clearance has been taken. And coming to the method of injection of the fat, so we did a liposuction, lipo of the abdomen fat or medial thigh fat, and we passed across the three-way cannula. Since there was no filters used there because of the cost matter, around 40 times we passed, 40 to 50 times, and we converted and we broke down the fat cells, and we filled with insulin syringe, and it was injected to the perineal region proximal to the repair site. And also the same nanofat is smeared over the nerve repair site or neurolysis site, and wound was closed. So donor site for the fat grafting was mainly taken from abdomen and middle aspect of thigh. In thin patients we preferred middle aspect of thigh, and liposuction was done in the same sitting as in the nerve repair. So this is a nanofat to transfer to the insulin syringes. This is another case of Oberlin transfer where the fat was injected to the proximal to the repair site, and also it is smeared and wound was closed accordingly. Coming to results and discussion, there was no donor site morbidity regarding to the fat grafting in our study till now. As our study is 7 months old, this March we have started this study. Long-term assessment for functional outcome is needed. And it was measured in the measured by regain of muscle strength 0 to 5, our muscle bulk and our conduction study. So basic nerve research study suggests an increase in regeneration and revascularization, as I said earlier. So since the use of adipocyte-derived stem cells in peripheral nerve reconstruction is relatively new, and more studies are needed to explore the safety and long-term effects of the peripheral nerve regeneration. And a very high quality clinical trials needed to demonstrate safety and efficacy for further guide in the development of protocols in clinical practice. Coming to the conclusion, in animal experiments demonstrated that various types of peripheral nerve surgeries have potential to benefit from addition of these adipocyte-derived stem cells. So this is adipocyte transfer is very simple, and it's cost effective and has zero immune reaction. And adipocyte-derived stem cell transfer has been proven beneficial for regeneration in multiple levels, including by secreting of growth factors and by morphing into Schwann-like cells, which can modulate genes that facilitate in peripheral nerve healing, especially in cases of brachial plexus cases, which needs very early functional rehabilitation. So there is need of randomized controlled trials evaluating outcomes of the peripheral nerve surgery with addition of these adipocyte-derived stem cells. Thank you.
Questions?
Hello. I just want to know, how are you assessing whether they're developing now fibrosis or?
Yeah, that is a thing. Actually, now study is 2 years we have kept actually. So it's 7 months. So depend, because you are not comparing with the other control groups. So we are just seeing the like improvement in the muscle power and any increase in the girth of the muscle bulk. So
no imaging.
No imaging as such. No imaging. That's why there needs more research in this field regarding nerve fat graft.
Thank you.
Yeah. How much fat do you inject? How much time? Yeah, sir. Only proximal to the repair site around half a cc, and proximal and distal sites, both nerve ends which to inject the perineal region, and while injecting we made sure that we're not injuring any the nerve fascicles, and mainly we used to smear a good amount of nanofat over the repair sites, sir. So that was one more thing we used to do, sir. Smearing, and studies also showing, animal studies showing that both injecting and smearing the fat around the over the nerve repair site has some benefits, sir. Because in plastic surgery normally we use for diabetic foot and wound management fat grafting. Nowadays 3D model have come, like 3D printing, and for wound healing. In that also we are doing only direct smearing of the nanofats over the wound and keeping for a week and after opening, and showing very good result nowadays. That's why we call it as a fat is the future in our plastic surgery. So, thank you.
Thank you. So we have our last speaker, Dr. Anuradha, and she'll be talking on arteriovenous fistula outcomes.
Good morning. I will be speaking on the effect of preoperative artery and vein diameter and velocity on the outcomes of the arteriovenous fistula. Our aim was to find a statistical association between the various factors affecting the AV fistula outcomes and to decide on selecting the target vessel so as to improve the dialysis outcome. We included the patients with end-stage renal disease between 18 to 70 of both genders. We excluded the patients with the peripheral vascular diseases, hypertension, sclerosis or thrombus superficial veins, and DVT patients. It was a prospective study carried out between 100 patients over a period of 3 years at MGM Medical College, Chhatrapati Sambhajinagar. AV fistula patency functionality was assessed at the end of 1, 3 and 6 months postoperatively. Working of the mature fistula which was used for dialysis had a blood flow of 500 ml per minute, venous diameter of 6 millimeters and depth less than 6 millimeters. Various statistical associations were applied to find out the association between all the factors, and a p-value of less than 0.05 was considered statistically significant. In the demographic profile, we found that the maximum age group was between 41 to 50 years. Mean age was about 53 years. We had 68 male patients and 32 female patients. We had 29 brachial fistula patients and 71 forearm level fistulas, of which mid forearm was 34. Diabetes was there in 14 patients, hypertension in 31, and no comorbidities in 55 patients. At the end of 1 month, in the results of the radiocephalic fistula, we found that the radial artery and the vein was not statistically correlating, but the PSV was found to be statistically affecting the outcome. At the end of 3 months and 6 months follow-up, we found that the radial artery diameter, the vein diameter, and the peak systolic velocity of the radial artery was statistically affecting the outcome in the working and not working group. Now, if we have to compare the same for the brachiocephalic fistula, we found at the 1 month and the 3 months, there was no statistical correlation between the brachial artery diameter, the vein and at the elbow, and the PSV of the brachial artery. The similar findings were confirmed at the end of 6 months. These were all similar to the previously published studies, except that what we found that the vein, in our observation, vein at the elbow and the PSV in the non-working group were very significantly low in the diameter. Age and the gender did not affect the outcome, and it was not statistically correlating. The hypertension was significantly affecting the non-working group and statistically correlating. The level of fistula selection also had a statistical correlation between the outcome of the working and non-working groups. So in nutshell, we had 100 patients, of which 29 were brachiocephalic and 71 were radiocephalic. Of the brachiocephalic fistula, the maturation rate was 70%, failure rate was 30%. The brachial artery diameters in working non-working group were almost similar to the previous published studies, but the vein diameters in our study in the working group was 2.2 and non-working was less than 2 millimeters, which was significantly lesser value compared to the previous studies. Whereas in the radial group, we had the radial artery diameter, vein diameter, and the PSV significantly affecting the outcomes, which were almost similar to the previous studies. Except that for the fact that the maturation rate in the radiocephalic group, we had slightly lesser numbers. 67 was the maturation percent. What we observed was in the patients where there was a good vessel diameter, but the low PSV at the both arm and forearm level, they did not mature. In conclusion, this study suggests there is a significant association between the pre-op vein artery diameter and the PSV with the outcome of the fistula at the end of 6 months. What we recommend is the minimal internal venous diameter of 2 millimeters for both forearm and arm level fistulas. For the forearm level, the radial artery diameter of at least of 2 millimeters. For the arm level fistula, brachial artery diameter of at least 3 millimeters. If the PSV considering radial level, we consider 40, and for the brachial at least 50 centimeters per second. The preferred level of fistula is the mid forearm level. If there are good vessels with a good PSV, we do always forearm level. If there are good vessels with a low PSV, attempt for the radial level fistula, which can be converted into brachial level if needed. Vessels, if the size is poor and the poor PSV, we do go for directly brachial level fistulas. If the vessel size is poor at the elbow with the low PSV, we'll look for the opposite limb for the fistula. We always control the BP before the surgery. Limitations of the study is assessed only the primary failures. It is a short duration of the study. Surgeon's performance is not assessed, and smaller level of brachial level fistulas included into the study. Thank you.
Any questions?
Well, how did you assess that the fistulas are working or not working?
Sir, post-operatively, we had done Doppler for all the patients at the end of 3 months and 6 months, sir. And it was, if it was meeting the criteria given by the Nephrology Society, only then we considered it as a mature.
Well, thank you. I guess we had a great first session. So we'll move on to the next one. That's a masterclass session.